Hello everyone. Hello everyone. In this video, we'll be discussing about the patellar mal tracking and dislocation. What are the risk factors and the imaging appearance? So the flow of presentation will be first we will see what is patellar mal tracking and dislocation. Then what are the risk factors associated with it? What are the clinical features and the points in history and examination? What are the imaging modalities that are present at our disposal? What are the telltale signs of patellar dislocation on MRI? How do we take measurements of trochlear dysplasia? What a radiologist can offer to the surgeon? Finally, talking about the management part, and then I will show you the sample template report. So as we can see, this is patellofemoral articulation, where patella articulates with the trochlear sulcus of the femur, and it articulates, it is congruent in this case, and it is supported by the uh, medial patellofemoral ligament on the medial side and lateral retinaculum on the lateral side. Vastus medialis obliquus is also very important in providing it support on the medial aspect. And the normal kinematics of patellofemoral articulation is affected by many factors, which includes, dynamic stabilizers, which is quadriceps muscle and particularly vastus medialis obliquus muscle. Then there are static stabilizers like patellar tendon, medial patellofemoral ligament, medial retinaculum, lateral retinaculum, and fascia lata. Then the bony structures like congruence between the shape of patella and the femoral trochlear groove. So normally in extension, this patella can lie either medially, laterally, or in the center. And lower 1/3 of patella, it articulates with the trochlear sulcus in extension. So as knee undergoes progressive flexion, patella goes more caudally and it articulates with the trochlear sulcus. So if there is any disturbance in the patellofemoral articulation, patellar dislocation can occur when there is progressive knee flexion. So what is patellar maltracking or dislocation? In patellar maltracking or dislocation, which is most commonly lateral, there is rupture of medial patellofemoral ligament and patella dislocates laterally. And so this is like a game of tug of war where, lateral sided structures, they pull the patella laterally because of lack of support on the medial aspect. So most commonly patella dislocates laterally. Only in some rare circumstances where there is lack of support on lateral aspect, patella may dislocate medially. So type of patellar dislocation includes transient lateral patellar dislocation, chronic patellofemoral instability, and recurrent dislocation and habitual subluxation. Risk factors include dysplastic patellar shape and trochlear sulcus dysplasia, which are most important factors. Then patella alta or high riding patella. Lateralized tibial tuberosity, which is measured by tibial tuberosity and trochlear groove distance. So more lateralized the tibial tuberosity is, there are more chances of, patella getting dislocated laterally. Then quadriceps imbalance is one of the factors. And in cases of medial dislocation, lateral retinacular release procedure, which is overdone, can lead to medial dislocation. So let's see the shape of patella. Weibuck classification has classified patella into 3 types. In type 1, lateral facet and medial facet are equal in length. In type 2, medial facet is slightly smaller than the lateral facet in length. In type 3, it is significantly smaller. So in type 3, the medial facet is quite small, and in such cases, there are high chances of patella getting dislocated laterally. When we talk about trochlear dysplasia, David DeJour classification has classified trochlear dysplasia in 4 types. In type A, where the trochlear sulcus is shallow, on lateral knee radiograph, we can see crossing sign where lateral and medial femoral condyle, they both cross each other. When trochlear sulcus is flat, we can see crossing sign as well as trochlear spur. When it is convex, we can see crossing sign with the double contour. And when it is like a cliff, all 3 signs can be seen: crossing sign, trochlear spur, and double contour. Next, let's talk about quadriceps or Q angle. So for measuring quadriceps angle, we need a long radiograph covering the pelvis as well as knee joint. We mark 3 points, that is anterosuperior iliac spine, patella and tibial tuberosity. We draw a line connecting these 3 points and take angle between this, which is basically 14 to 15 degree is normal. So if there is increase in the Q angle, maybe because of lateralization of patella, it can lead to more lateral force which pulls the patella. So there is increased lateral force on the patella from the quadriceps muscle and leads to lateral patellar translation. Next, see what are the clinical features. Patient can present with feeling like the knee buckled or gave out, sudden severe swelling and pain, and you can find, bruising around the knee joint and a bump noticed on the outside of the knee. And when patient is asked to flex or extend the knee joint, you can see patella dislocating laterally, giving reverse J sign. We have 4 imaging modalities available at our disposal, which includes conventional radiography, ultrasonography, CT, and MR. On conventional radiography, we can take skyline view where we can see, osteochondral fragment, and we can also see joint effusion on the lateral view, and we can see trochlear dysplasia. On ultrasonography, apart from joint effusion, we are not going to get anything extra, and there is no use of ultrasonography in cases of patellar dislocation as such. There is no published literature on it. Talking about CT, we can very well define the bony outline, but when we talk about soft tissue structure, CT is not that good. On MRI, we can see bone as well as cartilage. We can comment on the integrity of the ligaments, and we can also do dynamic scan nowadays. So what happens when patella dislocates laterally? So as patella dislocates laterally, the medial part of patella, it hits the lateral femoral condyle, and it leads to characteristic bone bruising within the anterolateral aspect of the lateral femoral condyle. And there can be edema over near the region of medial femoral condyle because of rupture of MPFL. So let's see this video where patella is dislocated laterally, and here we can see there is laxicity of the lateral ligament, and there is trochlear dysplasia, flattening of the trochlear sulcus. In this case, we can see edema over the lateral femoral condyle, characteristic edema over the lateral femoral condyle, and presence of osteochondral fragment or loose body over here, plus presence of edema over the attachment of MPFL over the patella. In this video, we can see presence of a chip fracture along the medial patellar margin and subtle edema over the lateral femoral condyle. In this video, we can see there is fragment over near the medial patellar margin and presence of edema over the lateral femoral condyle. Next, we can take Insall-Salvati ratio, which is measured by taking length of patella and patellar tendon. Then we divide the length of patellar tendon by length of patella. So normally it is 0.8 to 1.2. If it is more than 1.3, it indicates patella alta, which is a risk factor for patellar dislocation. Next, we can take trochlear TTTG ratio, trochlear tibial tuberosity and trochlear groove distance, where we draw a tangential line along the femoral condyle. Extrapolate this line at the level of tibial tuberosity and draw a perpendicular line which cuts across the tibial tuberosity, and it is perpendicular to the first line. Then we extrapolate this TT line, tibial tuberosity line, at the level of trochlear groove, and we draw another line which is perpendicular to the first line, and it cuts across the deepest part of trochlear groove. And we measure distance between the second and third line, which is TTTG distance. Normally it is less than 15 mm. 15 to 20 mm is borderline, and more than 20 mm indicates significant lateralization of the tuberosity. Next, we can give the depth of trochlear sulcus. So 3 mm is, up to 5 mm it is normal. More than 5.2 mm is normal. If it is less than 3 mm, it indicates dysplasia. We can take the ratio of medial to lateral facet length, and if medial facet is less than 40% of the lateral facet, it indicates dysplasia. We can take lateral trochlear inclination angle, which is, if it is less than 11 degree, it indicates trochlear dysplasia. So now let's see what a radiologist can offer to the surgeon. We can actively look for the telltale signs of patellar instability, even if the clinical suspicion is not high. If patient presents with pain in the extensor compartment, we can actively look for these signs. We can comment on the integrity of soft tissue structures like MPFL, vastus medialis obliquus muscle, and retinaculum. We can comment on the cartilage at the patellofemoral joint, and we can objectively give measurements of trochlear dysplasia, patellar height, etc. So non-operative treatment options are reserved for first-time dislocators in the absence of disruption of ligaments. They are immobilized for 3 to 6 weeks, followed by physical therapy to strengthen the quadriceps muscle. And then they are J-braced for all athletics or sports activities for 3 to 6 months. Surgical treatment option is indicated in cases of presence of chondral or osteochondral body, significant rupture of the medial stabilizers, persistently subluxed patella, and a second dislocation injury in cases of malalignment or dysplasia. So patient can undergo MPFL reconstruction or tibial tubercle transfer. This is the sample report template where we should comment on patellar and extensor mechanism, position of patella, patellar alignment, Weibuck type, patellar cartilage, MPFL integrity, quadriceps and patellar tendon. Then we should comment on trochlear groove depth, trochlear sulcus angle, lateral trochlear inclination, TTTG distance, and de Jong classification of trochlear dysplasia. We should comment on the patellar height, whether there is patella alta or patella baya. Integrity of the retinaculum, bone marrow edema, particularly in the lateral femoral condyle. Then menisci and cruciate ligament, femoral condyle and tibial plateau, presence of joint effusion, bursa or cyst. So that's all for this. Thank you so much.